Welcome all. Now coming on to the next session of the Retrograde CTO Academy. In this session, I would discuss about how to approach the CTO retrograde by this ipsilateral epicardial collaterals. So epicardial collaterals are many times very fragile and difficult to negotiate. So this is a case where the LED ostial CTO was dealt with the retrograde epicardial ipsilateral collaterals. So 60 clinical summary, 68-year-old male, diabetic hypertensive, old ACS, now presented with angina class 3, ejection fraction 50%, EGFR normal, and he has ostial LED CTO calcified filling by the ipsilateral epicardial collaterals. So this was his angiogram, and uh, we can see a good collateral coming from the high OM. So in aleocaudal, we can see that we cannot see any stump in the aleocaudal view, and the vessel is very calcified. And we can see that from the obtuse marginal, we are getting a good collateral ipsilateral from the this OM, and it is epicardial. So it was tried to negotiate it via integrate route, and various wires were chosen to deal with this. And over the fine cross microcatheter, filter XT was tried in first attempt. After that, we tried to go with the Gaia 1 and 2, but it was actually a calcified CTO segment, and we can see from the good collateral epicardial collateral retrograde vessel is not in line with the wire, so its wire is subintimal, and we can see a lot of calcium in that segment. So this integrate approach led to the wire going into the false plane. So at this stage, we can see this considering this for a retrograde approach because the CTO segment is long, it is has no stump, it is ostial, and it is difficult to go with the integrate approach. So it was taken for this retrograde approach, and we took the Caravel microcatheter into the high OM, and carefully this was negotiated with the sewer wire. So a very important thing is that with this epicardial collateral, we have to go with a very soft microcatheter like fine cross or Caravel, and we can try with the wires like Sion or Suo wire. Suo wire has deployed of for this 0.3 gram, and it's very, I think, safe wire, and we were successful to reach the distal part of the CTO segment, and microcatheter crossed into distality to the distal cap. Microcatheter can be seen, this caravel can be seen just near to the distal cap of the CTO. And tried to escalate the wire with the two, but actually this wire was not going from lumen to lumen. It had some false lumen. We can see it's not going into the true lumen, and it appears to be a very calcified long CTO segment. So this is a difficult situation that we are often stuck. So you can fluoroscopically clearly see there is a lot of calcium in this CTO segment. So what we were stuck with the situation, and we know that when you have a calcified CTO and your distal microcatheter or wire is not giving up, not coming into the lumen, then we are left with the option that is a knuckle card. So it's a promising technique, especially in calcified CTO segment where the retrograde wire and microcatheter we are not able to get both of these into the true lumen across the CTO. So in this retrograde knuckle was made, and it created some dissection in the subintimal base. We also tried to do some reverse Carolino, putting a dye, creating subintimal dissection, and we can clearly see there's a lot of calcium in the CTO segment, but where we were able to create some dissections in this retrograde approach. So now we took the integrate microcatheter, and over this we tried to negotiate the integrate wire Gaia 2. So after some efforts, we can see various wires were tried, and we were tried to negotiate this wire into the diagonal. So that means we were able to cross the CTO segment, and now there was downgraded to the filter FC, and we tried to come into the limit. So probably fielder FC in the main LED, and we could see the dissections created by this knuckle as well as the Carolino, and now there was a difficulty in crossing even the smallest of the balloons, and we could dilate it with the 1.5 to 10 millimeter of the this Ruri balloon, and then the non-compliant balloons were taken. So we were dealing with a calcified situation, and we could see the difficulty in crossing in the smallest of the balloons. So this is was the problem caused due to this lot of calcium. But ultimately, we were able to deliver two long discs into the LED, and this was implanted from LM to LED because while retrograde wire cross reached near the osteo of the LM. So just to avoid any dissections, it was decided to extend it from the left main to LED. And at the end, good TIMI 3 flow was achieved. So overall, this case highlights the importance of the retrograde approach, especially the epicardial route. And in this particular case, where the JCTU is around 4, so, take home from this is that in calcified CTO, many times externalization of the retrograde micro can be difficult. Therefore, knuckle cut and reverse Kellner technique can be used to create subintimal space for integrated wires. And ipsilateral epicardial collateral should be negotiated very gently with Shion or Suo 3 wire, which can negotiate the acute bend safely. And ping pong technique may be used, but many times it may not be successful in the cases of the calcified long segment CTO, as calcium obstruct the retrograde microcatheter entry into the guide. And ostial CTO with good interventionist collateral are indication of primary retrograde approach. Even ipsilateral collateral can be used. And failed integrate CTO are, of course, an indication for the primary retrograde approach. So thank you all for patient listening for this retrograde session. We would be coming with the next session soon. Thank you.